Good evening all. Let's learn about HRCT interpretation now. For a structured approach to the interpretation of HRCT images, the following aspects should be looked at carefully. What are all the dominant HRCT features and which features we are seeing location in the secondary pulmonary lobule and predominant distribution within the lung. For any diagnosis, all morphological findings from HRCT must always be combined with patient's history and additional clinical findings like pleural fluid, traction bronchiectasis. Patient's history is the vital thing in clinical thing. From history and clinical examination only, we have to elicit and we have to come to the conclusion or at least to the differential diagnosis. And let's see HRCT. What are the dominant pattern, whether reticular, nodular, high density, low density, and its distribution in the secondary pulmonary lobule, whether it is centrilobular or perilymphatic or random, and distribution within the lung, whether the predominant features are in upper zone or mid zone or central or peripheral, and HRCT features in ILDs. The scan shows diverse features which individually or in combination can indicate the presence of a certain type of disease. In diagnosing ILDs, there are 4 general features to be considered that indicate the presence of pathological abnormalities and are important to the interpretation. Reticular abnormalities, nodules, increased lung opacity, high attenuation, low attenuation. Further consideration of potential co-occurrence or overlap of features and additional findings and distribution of abnormalities in axial and coronal planes can help narrow the differential diagnosis. So these will all aid in the interpretation of HRCT and coming to the differential diagnosis. Reticular abnormalities. Reticular opacities are seen in HRCT as a result of thickening of the interlobular septa or fibrosis. Interlobular septal thickening is defined as thickening of the interstitium that surrounds the secondary pulmonary lobule by either fluid or fibrous tissue or infiltration by cells. It can have a smooth or a nodular or irregular appearance. It is the interlobular septal thickening. Visualization of numerous septa, which are normally about 0.1 mm thick, indicates an abnormal condition. What are the conditions in which interlobular septal thickening is seen? Pulmonary edema, lymphangitic spread of tumor, sarcoidosis, Erdheim-Chester disease, lymphoid pulmonary lesions. Then comes honeycombing. This is the pictorial form representation of honeycombing. The term honeycombing is used to describe the end stage of diseases that cause diffuse fibrotic destruction, and it is irreversible. It has got a poor prognosis. If honeycombing is present, it shows thick-walled, clustered, cystic air spaces of 0.3 to 1 cm in diameter, which are distributed subpleurally and basally. This is resemble a honeycomb in cross section. This feature is typically accompanied by other signs of fibrosis like traction bronchiectasis. Clinical and histopathological correlations of honeycombing: collagen vascular diseases, hypersensitivity pneumonitis, fibrosing sarcoidosis, NSIP, drug-induced lung disease, asbestosis. Then comes traction bronchiectasis. Traction bronchiectasis: bronchi appear to be pulled out, mainly seen in the peripheral part. Nodules. Nodules can be categorized in several ways, with the most important one being the distribution within the secondary pulmonary lobule. The distribution is essential for the accurate diagnosis of the nodular pattern. Nodules can be distributed in perilymphatic or centrilobular or random way. Perilymphatic distribution. They are present in the interlobular septa, pleural spaces on the bronchovascular sheath. Most commonly, perilymphatic nodules are seen in sarcoidosis and malignancies. Centrilobular. Centrilobular nodules are present only in the centrilobular region, spaced 5 to 10 mm in the pleura, from the pleura, up to 1 cm in size. Although not necessarily in the center of the secondary pulmonary lobule, the pleural surfaces are spared. They can appear either in rosettes or can be diffuse, not necessarily disease related. Random distribution of nodules. Randomly distributed relative to the structures of the lobule throughout the lung parenchyma. They can be associated with hematogenous metastasis, miliary tuberculosis, miliary fungal infections, or Langerhans cell histiocytosis, early nodular stage. Coming to tree in bud sign. This is the pictorial representation of tree in bud sign, tree in bud pattern. These are the centrilobular nodules, can be accompanied by structures called tree in bud opacities, which resemble a budding tree. This picture shows a branching structure. It represents an impacted centrilobular bronchus dilated by pus, mucus or fluid. This occurrence is almost always associated with inflammation due to pulmonary infections. The identification of Y and V-shaped structures on HRCT images is of value for narrowing the differential diagnosis. Predominantly, it is seen in tuberculosis, hypersensitive pneumonitis, respiratory bronchiolitis in smokers, uncommon in bronchoalveolar carcinoma, pulmonary edema and vasculitis. High attenuation. Increased lung attenuation refers to opacification on HRCT images that can either obscure underlying vessels in the case of consolidation or present without obscuration and in so-called GGOs. Let's meet in the next video.